So my topic today is neuroimaging and requesting appropriate imaging modalities and the appropriate imaging MRI protocol for patients. So this is a broad topic. So we're just going to touch on all the different types of imaging that we do, mainly focused on CT and MRI, which is what is available in this hospital. And we can clarify any issues that you have regarding requesting later on if you have any questions. So this talk is basically divided into 3 parts. So first we're just going to touch on filling out request forms, which is an issue sometimes that we face, and then CTs and MRIs. So when you are requesting imaging of any type, there are 3 things that you need to fill in the request form. The first thing is the patient details, the name, age, gender, which ward or clinic the patient is in, and the requesting doctor. So this is an issue here because we are still using paper requests. So if we in the future move on to electronic requests, these things will be automatically populated in the request form. So you might not have to worry about it in the future. But for now, for identification purposes, you need to accurately fill out this part of the request form. Then the second thing is we need to know why this patient came to the hospital. So we need to know what the presenting complaint is, and it would be nice to know which side the symptoms is on, whether it's an acute thing or a chronic problem, and if there are any relevant past medical or past surgical history. So you don't need a big history. So for example, if your question is this patient having a space occupying lesion, it would be good to know if the patient has had a previous history of malignancy, or if this patient is undergoing like a lumbar MRI, if the patient has had a previous lumbar spine surgery, which is relevant, we need to know about it. So that will make things easier and make it quicker to issue the report. So these are the main things that we need to know. Then this is the most important part. So the specific clinical question is something that we don't usually write in a request form. So during my overseas training in the UK, they have a specific column in the request form for the specific clinical question. So here in our request form, there is only a box for the history. So in the UK, they have a special column for the specific clinical question. So that is very important because then we can target our report for your clinical problem. So sometimes you can, sometimes in the request form, you might give a DD that this is what you clinically suspect. But because that column is not there in our request form, you might just write the history also. So it would be really good if you mention what you are clinically suspecting or what you want to exclude by doing the imaging modality. Then the report would be more targeted to the clinical question. So the main imaging modalities in terms of neuroimaging in this hospital is CT and MRI. So there are various advantages and disadvantages of both modalities. So we have to use them in conjunction so that we can diagnose the patients appropriately. So when it comes to CTs, the cost is lower, the scans are faster, so it's good for critically ill patients. It's relatively freely available because of the shorter duration of scans. There are more slots. The negative thing is the radiation exposure, so it's better to avoid it in pediatric group and in pregnancy, especially repeat scans in pediatric patients. MRI, it's more expensive. The scan takes a longer time to do. So because of that, there are less slots. So we need to triage the patients who really need these scans. And if possible, always go for a CT first. If that can give the answer to the clinical question. The other thing is there are various safety issues related to the strong magnet. So if the patient has a pacemaker or an implant which is magnetic, that might become a safety issue. So it might not be useful for critical ill patients who can't give a history, or if there are no previous records available. So we'll briefly go through the common use cases for CT. So CT is very good for trauma. As I said before, you can quickly do the scans. So it's good for critically ill patients. You don't have to worry about the pacemakers, implants. It's very good to identify acute fractures and also identify ICH in the acute situation, also to identify things like brain herniation, hydrocephalus. So yeah, so we'll go on the right side, and this picture is a patient who has traumatic brain condition. So CT, as you can see, it shows this imaging, these issues very findings clearly. So another use case is of course strokes. So the main goal of imaging in acute situation is to exclude an ICH, and CT is again very good to identify an acute stroke. You might not be able to pick up the infarct if you do the scan very early. So because it takes a few hours for the infarct to mature. So as you can see in this image early, so you're not seeing the infarct very clearly. If you see there's a very large established incident stroke on the right side. So if you repeat the scan, you might be able to pick up the stroke sometimes if it's not shown on the first scan. Then in patients with acute severe headache, to exclude subarachnoid hemorrhage, it's a good imaging modality. So it's very sensitive to acute hemorrhage. Then in patients who are suspected of raised ICP prior to lumbar puncture, to exclude space occupying lesions, to exclude brain herniation, and to look for hydrocephalus, CT is good enough. So the large meningioma. So you can see it's causing mass effect and brain herniation. Patient who has had a lot of cerebral edema, you can't see the ventricles even because of the swelling, extradural hemorrhage. This is a patient with bilateral subdural hemorrhage. So CT is good to look for features of raised ICP. And then sometimes we can give contrast to these patients, especially if there's space occupied lesion. It's good to characterize tumors, metastasis, and abscesses. So this is a patient with a brain abscess. You can see there's peripheral enhancement. Another use case is CT angiograms. CT angiograms, we give IV contrast and take images. And the good thing about CT angiograms is there's less flow-related artifacts compared to MRI angiogram. So in MRI, what we do is a non-contrast angiogram, and we detect the blood flow of the within the vessel. So it's the signal that we are seeing is related to flow. But in CT angiograms, we give contrast, and the vessel will fill with contrast. So if there's a filling defect, you can easily identify it with less artifacts. And modern CTs are very high resolution, so the resolution that you will get in a CT angiogram will be higher. So that will also be better for diagnosis. So you can do this if you suspect aneurysms, arteriovenous malformations, and vascular occlusions or stenosis in stroke patients. If you suspect arteriovenous malformation, and a CT angiogram is enough, you don't really need to do a CT venogram, because what we are looking for is opacification of veins during an arterial phase. So if there is a arteriovenous malformation, you will see arterialized veins. So a CTA should be more than enough to diagnose it. So this is an example of a CT angiogram image and MR angiogram image. The MR angiogram is not as, the quality of images are not as good, and the margins are a little bit fuzzy compared to a CT angiogram where the margins are very crisp. So sometimes you might get if the vessel artifact, because the scan is basically looking at flow in one direction. So those things so you might get false artifacts which you might interpret as stenosis. And sometimes you might get aneurysms which are directed lateral from the vessel wall, and then and because of that, you might get artifactual negative results on MR angiogram compared to a CT angiogram where you're giving contrast and the contrast fills the entire vessel. So again, like CT angiograms, you can do CT venograms. And in CT venograms, again, we do contrast, venous sinus thrombosis. You can see sites. So again, CT venogram is very good to identify venous sinus thrombosis. And again, because there's less flow-related artifacts, it's very sensitive, and it's in most occasions it's better than MRI to say whether there is venous sinus thrombosis or not. So the only advantage of doing an MR angiogram is to look for any venous infarcts. But in order to diagnose venous sinus thrombosis, it's better if we can do a CT venogram, because it's one thing is widely available compared to MRI, and then again there's less artifacts. So this is an example of a CT venogram and the high resolution. And these field defects that we are seeing are actual real things rather than flow-related artifacts that we might sometimes see in MRI. Then you can do CT cystostomograms in order to identify patients with CSF leaks, especially if they've had a previous trauma to the skull base, or if there's been a previous surgery and the patient is coming with CSF rhinorrhea. You can do a CT cystostomogram to identify CSF leaks. So these are some examples. Then another type of CT is CT-IAM. It's good for identifying congenital abnormalities and things like mastoiditis, bone erosions, and so this is an example of a CT-IAM. Then, depending on in addition to the brain, you can do CT sinuses if your main worry is the sinuses, because in the CT brain you might not actually cover the entire sinuses. Sometimes you might get cut off. So if your main worry is the sinuses, you can either do the sinuses, or if you want to know about both, you can combine the two and do it as well. So similarly, orbits as well. So orbital CTs, it's good for identifying orbital tumors. You might see fat stranding in patients with orbital cellulitis or orbital fractures, also for subperiosteal abscesses. It's not very good. I mean, it's not good to identify optic neuritis, but for other things like masses and collections, it's good enough. So now we'll move on to the MRI protocols. So MRI protocols will vary from institution to institution, and it will depend on many factors. So the main thing it will depend on is the clinical question. So that is why it's important to mention that in the request form. So there are so many MRI sequences. You can do it in many planes. You can do it in 2D or 3D. And if you try to do all the MRI images in one patient, you might be able to do one study for an entire session. So that's why we need to tailor the imaging modality for the clinical question the patient is having. So at our hospital, this is the routine MRI protocol that we do. This is the routine MRI non-contrast protocol. So we do a DWI, that's diffusion weighted imaging, that's Kuppler flare, and a sagittal SWI organ bone sequence. So these are the ones that we usually do. So out of these ones, now in some hospitals you can they do even a limited protocol where they don't do the SWI and do the other ones. But I think in our hospital we do which works for us, because then the recall rate also goes down, and sometimes we don't have the full history, and then when we do the scan we might have to recall the patient for additional imaging. So this I think is the one that we have settled for at the moment. And as you can see, we do imaging in different planes so that we cover different areas. So kind of lesions in the brain tissue. So this is a DWI sequence. It's good to identify T1. So the sagittal ciliary T1 image we do in a 3D manner rather than 2D manner. So there's no interslice gap. So that is good for patients who we want to assess the brain volume, like dementia, neurodegeneration. So if you do 2D sequences, sometimes you might get artifactually, you might get volume averaging artifacts, and then you might misinterpret either atrophy or not. So at the central TP image, it's also a bright spot. You can see the size of the cella, you can see the size of the pineal gland, you can check tonsil herniation. So this is a very useful sequence. So this is what I mean by this 3D sequence. As you can see, so this is what we call a 3D sequence. So it's like a video where there are no slice steps. So we can accurately assess the volumes, and we can reformat it into different planes, axial or coronal, and assess the brain parenchyma. So that's very good to good for brain atrophy, dementias, and such. So this is a SWI sequence. So this is good to identify microhemorrhages or calcification. So if you have a tiny hemorrhage, this will amplify it and show it very clearly. So that's good for patients with vasculitis, patients with hypertensive microangiopathy, patients with even trauma, patients who've got diffuse axonal injury. It's very good. So these are some of the indications that we can use routine MRI brain without contrast. So headache, query, space occupied lesion, hydrocephalus, stroke. So for stroke, we can do the routine one, or we can do a limited stroke protocol with DWI, flare, and SWI. So the DWI to the hemorrhage or hemorrhagic transmission. So by using these sequences, you can identify acute strokes as well as established strokes. So you can do a limited protocol if you want to go for strokes. Then Parkinson's disease, I think it's important to do a susceptibility weighted imaging, and these are the other one. The protocol again has a 3D T1 image and SW, this ASL perfusion, which is an on-contrast perfusion imaging modality. So all these, the dementia protocol, the Parkinson's protocol, stroke protocol, everything is included in a routine brain protocol. So we don't have to worry about separate protocol for these patients. Then there are certain indications where we give contrast. So these include HIV, toxoplasmosis, then other inflammatory conditions like sarcoidosis. If there's a known history of malignancy, it's limited in contrast because sometimes meds might not be obvious on the contrast scan. It might be very subtle, like meningeal enhancement or cranial nerve deposits, so we need to give contrast. Then brain tumors, again, we need to give contrast for these patients also. Now, so we can do perfusion imaging and MR spectroscopy if there is a doubt whether a mass is a tumor or not. So we don't routinely do perfusion imaging at Kandy. Pre-test is again more sensitive. So we tend to do it if there is a doubt whether a lesion is an inflammatory lesion or a tumor, and it usually helps us in differentiating the two. Then we have a separate epilepsy protocol. So these are some of the indications for an epilepsy protocol. Again, for pediatric epilepsy, we are looking at like tiny cortical lesions and developmental malformation. So internationally, the recommended standard is to go for a 3 Tesla scan because of the higher resolution. For patients, adult patients, so if a patient in his 40s or 50s just come with a single episode of seizure, a regular MRI scan of the head should be enough, because we are not really looking for like tiny cortical malformations in those patients. So those patients might have tumors or post-traumatic encephalomalacia. So the regular MRI brain should be able to identify these abnormalities. So this is an example of a T1 image. The second one is the 1.5 Tesla machine in one of the private sector scanners that we have here. You can see there's a huge difference in the angle detail that we can see. So it's one area that which we look for in epilepsy patients. So we can identify structures. So if you compare it with the 1.5 Tesla machine structure, but if you look at it in the 3 Tesla scan, you can see the hippocampus proper between the two layers. You can see the white matter tract going above it. So you can see a whole load of details if you do an epilepsy scan in a 3 Tesla scan, and this is important for pediatric epilepsy. And again, you can see the basal ganglia. You can see all these nuclei separately sometimes. So this is again, so the top, you can see the hippocampus here is just a single. You can see better by differentiation. It's easier to identify cortical abnormalities. Cortical is also less in 3 Tesla. Yeah, so this is our routine epilepsy protocol, and then what's important is for each, that's to identify vascular malformations and caminomas, especially in adult patients. Caminomas are very common cause of epilepsy, so it's important to do it. If you don't do it, there's a good chance if it's small, you might miss it. So in team sections, and that's to assess the hippocampus and temporal cortical abnormalities. Then for demyelination for patients with MS, we'll do a 3D flare sequence because these lesions can be very small. So Now, this is an example. This patient is facial lesions. You can see a tiny lesion in the pons periventricular lesion. So if you quickly report it, if you have a big reporting pile and you're going through it, there's a chance you might just miss one of these lesions. And if you do it in 3D, if you do it in 2D sequences, because the lesions are very small, you might not catch the lesions, or you might catch a part of it and just disregard it as not significant. And this is another example. So this is another fibrosis, as you can see, and this is a gene of the derivative phase. So identifying these subtle abnormalities can end up being can have a significant impact in diagnosing a patient as having or not having MS. So if you do a 2D sequence, there's a good chance you might not be able to accurately say whether these things are subcortical or juxtacortical. This is an example done on the tiniest level, and difficulty is not as good at that. Then this I just added because inversion recovery sequence, so it's even more sensitive than a flare sequence. So because it suppresses the contrast between the lesions is even more. The flare sequences, the B and C are in the double inversion recovery. So we don't have it here, but it's something that can be done if it's available. Then we have a separate pituitary protocol for all the pituitary issues, pituitary adenoma, precocious puberty, acromegaly. So the thing is, pituitary gland is a really small structure, and if you don't do dedicated sequences for the pituitary, you might not pick up subtle abnormalities. So if there's a large macroadenoma, of course you will be able to see it on a regular scan, but microadenomas and small case cases you might miss on a regular scan, especially if you don't do a sagittal sequence. So we do targeted pituitary sequences which have a better resolution, and the pituitary appears larger on those. And for these pituitary scans, we can do the pituitary and then just do some limited imaging of the brain, like T2 axial and DWI, just to exclude any significant brain pathology. One of the issues that you encounter is some of the private sector scans, how they have their protocol set up is they do the entire brain protocol with a lot of unnecessary sequences, and then on top of that, they do the pituitary protocol. And the patient has to pay a huge amount of money for 2 scans, and 1 scan is completely useless. So this is an issue. So you don't need to do the full brain protocol. If you're worried about the pituitary, you can just do some limited imaging just to exclude anything significant. So it's very small. So this is a coronal T2, and you can see the pituitary as much larger structures, and you can see the pioneer germinal with connecting the simulations here, and you can see it characterized them very nicely. And if you suspect microadenoma, you might have to also do a dynamic study to explore the team. Then we have MRI orbits. So these are some of the indications for MRI orbit: profile, reduced visual acuity, ptosis, thyroidopathy, orbital mass. So dedicated images for the orbits plus some limited imaging of the brain just to exclude any orbits optic. So we might have to do full MS protocol, but otherwise you can do a limited scan. Now for MRI orbits, the most important sequence is the coronal stir or the coronal T2 image. So this is so why I say it is. Let's see. So this is a patient with optic neuritis, and you can't really see which side the abnormality is. Both sides look similar. The right optic nerve is brighter compared to the left side. So this is the abnormal side. So it's very easy to diagnose an optic neuritis on coronal stir, but it's extremely difficult to diagnose it, and you might overcall or undercall optic neuritis on axial sequence. So this is what we do in our hospital. Then for trigeminal neuralgia, the most important sequence here is actually add an MRA to it. If you're doing only one sequence, this is the one that's more helpful because you see both the nerve and the artery. Whereas in the MRA, you only see the artery. So to see microvascular contact, this is trigeminal. So protocol is a very heavily T2-weighted sequence where you don't get a lot of brain parenchymal detail, but you see a huge contrast between the brain surface and the CSF. So again, it's 3D sequence, and we can do it for the area that we suspect, as in this case, the trigeminal. You get a lot of problems. If you just the angiogram, the problem is you don't see nerve. So it's good to have an angiogram because sometimes you can correlate the two. If you have a doubt whether the structure you see in the cyst is a vessel, but if you're doing one, it's better to do the cyst. Again, the same thing can be done for the IAMs. So this is a patient who's having, again, so you can see it clearly on the cyst. Mhm. Then we move on to the skull base and the face. So very often we get requests for patients who have problems in the face and skull base and in the soft tissue of the neck, and the request says MRI brain or MRI C-spine. So MRI brain and C-spine is for the brain parenchyma, and C-spine is for the spinal cord. So if a patient has a lesion in the face or in the soft tissues of the neck, that won't adequately cover that region. So you need to do some additional sequences with this stir imaging, and we need to have a wider field of view to cover the entire area of the soft tissue. So you need to give fat separation even if you are giving without contrast as well as with contrast to identify lesions in the skull base, because sometimes lesions can be masked by the fat in the skull base. So again, for the soft tissues of the face, you need to do sequences with fat separation. So that's the main difference between the regular CT brain that we do. So this is helpful for the soft tissue mass, facial infection, dental abscess, like that. So this is, you can see some deposits in the face. If you don't give fat separation, all of these deposits might be missed because the fat will not be bright. So you can see the fat in the subcutaneous plane has been suppressed. So now the lesions are clear. Bear with me a little bit. I think there's this computer is stuck. So we can do, as I previously mentioned, angiograms in MRI. We can avoid giving contrast. So if there's a contraindication for contrast, we can do non-contrast MRI angiogram. So it's not as good as a CT angiogram because there's more artifacts, but still we get good image quality, especially if you do it at 3 Tesla. The image quality is much better than at 1.5. So this is an example of an MRI angiogram. So these are some of the artifacts that you can see. You can get some, and you can misinterpret this as flow artifact in the middle of the vessel. So in this one, you can see there's a tiny apparent narrow segments. That's also a filter. So yeah. So it's important when you're interpreting also to know about these things. Otherwise, you might false call normal area stenosis as well. And the problem is, when you have a narrowed segment like this, if there is an actual stenosis, then you're in trouble, because so if you tell that it's a artifact and it turns out to be an actual narrowing, then again it's an issue. So that's why CT becomes better, because all these things can be avoided. I mean, MRI you can do for venous thrombosis, but we prefer a CT in the first instance because it again has less artifacts. So this is a superior sagittal sinus thrombosis. So you can see the flow in the superior sagittal sinus. Then for carotid dissection, there's a special protocol where again we do fat suppression for this fried egg sign. So when you have a carotid dissection, you get an intraluminal thrombus, and thrombus can be picked up by doing a T1 sequence with fat separation. If you don't do fat separation, it could be just a fatty otherwise plaque as well. So that's other DD. So usually these sequences are combined with a non-contrast time of right angiogram as well to look at the caliber of the vessel. And this is something that's around, so and to identify aneurysms at risk of bleeding. So now, when we do regular MRI scans of the brain or CT scans, we look for indirect evidence of vasculitis, such as hemorrhage, small vessel ischemic change, or infarcts, which are the consequence of vasculitis. So traditionally, the definitive diagnosis of vasculitis, you need to get a pathologic sample, you need to get a biopsy of the vessel wall. But the next best thing is to do a black blood vessel wall imaging. And that's that's a newly developing area which people are doing in other countries now. So in that, the signal in the vessel, within the vessel is suppressed, and you do pre and post contrast imaging and try to look at vessel wall thickening and vessel wall enhancement. So that is one thing. And then again, for aneurysms also, if you have a lot of inflammatory change around the aneurysm, it's an indicator that there is a higher chance of rupture for aneurysms. Then soft tissue infections, and also like to look at lymph node metastases, laryngeal cancers, that sort of thing. And again, you need to do fat saturation sequences and contrast for these patients. And so this is an M scan. You see a lot of the peripheral soft tissue also in the field of view. It's a cervical spine scan, and that in order to get the maximum image quality for the session pulses, so that the other moving parts of the larynx and pharynx are suppressed. The signal coming from those are suppressed. Whereas soft tissue neck involves like a wider field of view. So those are two completely different protocols. And if you are requesting scans, you have to make sure you request the appropriate one. So if you want to know whether the patient has cervical myelopathy, you need to request a MRI C-spine. If you want to know if there's like a soft tissue mass in there, you need to request the soft tissue neck protocol. Then spine. So spine, there are several, generally, a degenerative spine protocol or a backache protocol is more than enough. Then there are additional sequences like STIR and DWY and contrast, which you can use in specific situations. So this is what a T1 and T2 and a T1 sagittal image, and then you have to identify cord compression, any spinal cord lesions. The T1 is useful to identify any bone lesions, and the axials are helpful to look at the exiting foramina and the spinal cord. So this is what I would recommend as a basic protocol for the spine. And if the patient is having a scoliosis, or if you want to look for cervical ribs, any number 3 to sequence is also helpful. So yeah, so basically when you're imaging spine, it's good if you can request the appropriate area. So if a patient is having cervical myelopathy, rather than requesting the whole spine, it's better if you can request just the cervical spine, because it takes a longer time to do the entire spine and it might not be clinically useful. So if you have a problem with the thoracic spine, we just request the thoracic spine, or you can combine two as well. You can do cervical and thoracic spine if you want to look at the spinal cord. And if you have a patient with lower back pain, it's better to just request the lumbar spine, because otherwise it just takes up a lot of scan time and it's going to affect the number of studies that we can do. So these are some of the indications for lumbar spine scan. And of course, sometimes you need to do the whole spine as well for certain patients. Then there's another sequence called the STIR sequence. STIR it's basically a T2 sequence with fat suppression, and it's good to identify edema. So it's very useful in trauma to identify subtle undisplaced fractures, to identify ligamentous injuries, and also to detect spinal cord lesions. So sometimes you might get myelitis, which looks entirely normal on a T2 weighted sequence, and if you don't do a STIR, you might miss it. So I have seen patients with myelitis which is only shown on the STIR sequence. So if you suspect that, it's good if you can do this sequence. Yeah. And for trauma. So trauma and myelitis are the two main indications, and also for bone mets, it sometimes helps. So this is an example. So this is a T2 image, this is a T1 image, this is traumatic spinal cord contusion. You can see it very clearly on the STIR, and you can see in addition to the cord contusion, the ligamentous injury is best demonstrated on the STIR. If you don't do this, you might miss the ligamentous injury in a trauma patient. So this is another patient who's having a discitis. Again, you can put on a STIR sequence. So the edema is best shown on that. So if you have a suspicion of discitis, it's good if you can request a STIR sequence. Now, this is a patient with patient has had a scan with only T2 imaging. It's really difficult to identify the abnormality on the sagittal image. Spine scan axial, and you can see an thoracic spine. And if they have not done axial for the thoracic spine, you might miss the myelitis. So if you suspect a myelitis, it's better if to do axials covering the entire spinal cord. So that means the cervical spine and the thoracic spine, and the axials in the lumbar spine won't be that useful. The other thing is, but only doing T2 imaging is, you might miss important abnormalities like metastasis and discitis, which can have like serious consequences. So this patient who's had this scan, the T2 scan looks as a metastatic deposit here. So if you only do this scan, this might get reported as normal, and then the patient might come in a few months with more symptoms and untreatable condition. So I've seen several scans with discitis as well. There was one patient who had seen the first scan at initial presentation, and then it was not identified on that. And then the patient came with another lesion in the thoracic spine with a cord compression with paralysis. So if you're not doing a T1 scan for the spine, you can have serious consequences. So doing the backache protocol, I think, is the best way to avoid these things. The axils of the cervical spine, which nicely demonstrates the series. Then we can do diffusion weighted imaging for spine. So this is very helpful for patients who suspect spinal cord infarction. So some of the patients who come with myelitis-like changes on the scan might actually be having an infarct. So if you clinically suspect that this patient is having an infarct, if the patient presents very acutely or if there's severe back pain with the onset, you can do a DW. So this patient with intensity in the anterior part of the spinal cord, one of the diffusion weighted imaging, you see the diffusion restriction. So this patient was diagnosed to have a spinal cord infarction. So MRI of the spinal cord, again, as I said, it's important to do axial sections of the cervical and thoracic spine if you suspect spinal cord pathology, and you might have to do stir sequence, and if there's any abnormality, you might have to do contrast as well. So contrast functions in discitis and in Guillain-Barré syndrome to look for any nerve root enhancement. So if a patient is having known metastasis and is coming with quadriplegia and you want to exclude a spinal cord compression, you don't really need to give contrast. You can do the other T1, T2 and stir sequences, and rather than waiting and preparing a patient for contrast, because all you need to know is where the mets are and where the compression is. So for that situation, because it's a relatively urgent thing where you might have to send for surgical decompression, you can just do the non-contrast scan. Then again, it's important to do fat saturation. We recently got who we think is having potency, hyperintense, which is very hyperintense, and this is the fat saturated T. This image is also a sequence. So you can't see the enhancement clearly on this. So in order to pick up the contrast for spinal cord patients, we need to do fat separation, and that's what we are implementing in our hospital now. So I'm not going to do this once because we don't have these imaging readies. Then we can do brachial plexus, lumbar plexus. So for cervical, it's for trauma. The thing is, for trauma, it's better to do it after a 6-week delay because sometimes you might miss the abnormalities on acute scan if there's a big collection or a lot of edema in the neck. So what's recommended is to do the scan after 6 weeks for acute trauma patients. Then we can do MRI of the muscle. So when you're doing muscles, it's important we can do upper limb, lower limb, or both. And it has to be done with the one and a stir. The T1 is to assess the muscle bulk to identify where the inflammation is, where the edema is, so that you can, if you want to take biopsy, you know where to put the needle. So we have some specialized protocols for pediatrics. Skip those. So the take-home message is we need a short clinical history and ideally a clinical question for all the scan requests. So it's not too difficult. It's better if you can not write a big history also, because then it takes time to go through it. So if you can have a short clinical history and a specific clinical question, it's going to be very useful. And also it's important to mention the side where the abnormality is. So sometimes we get requests like patient is having trigeminal neuralgia, and then you try to figure out like where it is it on the left side or the right side, and that takes up a long time. So it's good if you can mention those. Then we have CT and MRI, and for certain indications CT is actually better. So try to do CTs if you can, and if you can't sort out the clinical problem, you can do an MRI, and then especially for follow-up, the CT might just be adequate as well sometimes. Yeah, and then MRI scans of the spine. If you do the scan without T1 weighted sequence, the effects might be serious for the patient sometimes. That's the take-home message, and I can take any questions.